This is Bishop Edgar Vann, and tonight this is the VannTage Point. I am so excited and delighted, as I always say, to have this opportunity to reach you wherever you are, to let you know that we're always seeking to inform, infuse, and inspire each and every one of you toward a better way of life, and certainly a life that is more abundant for us all. There is a biblical principle that says that certainly our people are destroyed because of a lack of knowledge. And so I do everything I can in the VannTage Point, whether it's my quotes that you may see on social media or these shows that we do, to make sure that our community is duly informed. Well, I am really privileged tonight and very honored to have a tremendous guest with me tonight, sharing on the VannTage Point with regard to the COVID-19 crisis and the COVID-19 vaccine. As you well know, in the last week or so, last couple of weeks or so, there has been a dramatic surge again in the Detroit area and throughout the state of Michigan. Michigan literally leads the United States right now in terms of these confirmed cases, and our hospitals and hospital emergency rooms are full again in another surge of this virus, and of course with the prospect of the vaccines helping us to come out of this. And so tonight, I couldn't think of a better person to bring in just one-on-one tonight for us to talk about this in depth. I want to have the opportunity to bring the latest information to you, factual information to you from my expert tonight. This expert is Dr. Herbert Smitherman, and I am uniquely and intimately acquainted with him for over 25 years. I know him to be not only one of our most brilliant minds that we have in our city, but certainly one of our most astute professional and medical professionals that we have in the city of Detroit, throughout this region, and of course, in this nation. Dr. Smitherman, I'm so grateful to have you tonight. Good evening to you, sir.
Thank you so much, Bishop. I tell you, thank you for that very kind introductions, and thank you for all you do in this community.
Well, you know, there's a lot of things. I like to make sure that our people know who our people are. And I think it's very important that people understand your level and body of work, your achievements, what you've been able to accomplish in the medical field, and of course in other fields of diversity, fields of inclusion, and of healthcare equity. Dr. Smitherman is the president, the CEO of Health Centers of Detroit Medical Group, and also its foundation. They operate 3 health centers in urban Detroit, and whenever I pass by one of them, they're always full of Detroiters who trust Dr. Smitherman and his staff for their health care. He's also the Vice Dean of Diversity and Community Affairs at the Wayne State School of Medicine. He has a very important and significant role there at Wayne State University. We've heard in years past about some of the dilemmas of the medical school at Wayne State. Dr. Smitherman is not just a medical doctor, but also an activist, a community steward. He is a person who has advocated very strongly and aggressively for a sense of inclusion there in the Wayne State Medical School. So we're proud of him there. He's a professor of medicine. He also works with the Carmanos Cancer Institute. He is truly an expert in urban-based primary care. And so I'm privileged to have him tonight and to start this conversation. Well, Dr. Smitherman, listen, we are well aware of the effects of the COVID-19 vaccine, most especially in the last 14, 15 months here in the Detroit area. What a devastating blow it has been to us. What a deep impact COVID-19 has had in the blackest city in America, which of course is the city of Detroit. And so why don't you just start out as we talk about the virus, what exactly is COVID-19 and why has it been so pervasive in our community?
So it's a virus, just like the flu virus or the common cold virus or the chickenpox virus. These are all viruses that infect humans. This is the COVID, or the coronavirus, is what's called a novel virus, meaning it is a new virus that really showed up around January 2020. And so it was from Wuhan, China, developed, sort of mutated there, and has traveled really across the world. And because it's a new virus, meaning that it is a virus that humans have never been exposed to, humans had no immunity. And it was a highly infectious and contagious virus with no immunity within humans, so it spread very quickly. Right now, the United States is in its fourth week of an upward trend in the COVID-19 cases. This is our fourth surge in the United States. The largest surge was like between November 2020 and January 2021. But now we're having a surge in cases, largely because many states are lifting some of their social distancing policies and mask mandates in some areas that are contributing to this increase. This increase could also be due to the presence of a more contagious variant of the COVID-19 virus, which is what's called the UK variant from the United Kingdom. We have in Michigan, we have the COVID-19 is surging more than any other state. We're number one with respect to the surge, largely because we see a lot of cases in Michigan among kids and young adults between ages 10 and then 39. Those cases have risen about 133%, largely because, you know, we've opened up sports, et cetera, for kids. And kids have now come together playing sports, soccer, you know, football, basketball, et cetera. And as the kids are intermixing, they are passing along COVID. Many of them don't get sick, but then they pass it on to adults. And the lucky part is about 65% of our seniors age 65 and above have actually been vaccinated. And so we're protecting the older seniors, but a lot of the young people who have not been vaccinated are getting COVID. The good news is, although our cases are going up, we haven't really seen a real surge in death rates. And a lot of that is because of vaccination. So although we have the highest surging rates, and Michigan is the second highest number of cases related to the variant, that is the UK variant, the largest variant in the United States, you know, which is actually a little more contagious than the original strain, and has a little higher lethality or cause and death. So, you know, we're having a surge in our state, largely because, you know, we need to wear a mask, we need to still social distance, we need to avoid crowds, we still need to wash our hands, and we still need to make plans to get a safe and effective COVID-19 vaccine, because the vaccine is the only way we're going to stop this spread. And right now, Michigan is we have about 23% of the population fully vaccinated. Fully vaccinated means that you've gotten, if it's a 2-dose vaccine, you're fully vaccinated 2 weeks after the second dose. If it's a single dose vaccine, you're fully vaccinated after 2 weeks after the first dose. So we're about 23% of our population is vaccinated. The range in the United States is Alaska is 30% and Georgia is 16%. I always say if Georgia focuses on getting people vaccinated as opposed to trying to prevent people, Black and brown people, from voting, they probably be in a better state. And so the focus needs to be still, as we get vaccinated, we still need to wear masks, socially distance, avoid crowds, wash your hands, and we still need to get that vaccine. So that's sort of where we are with respect to our vaccination rates, our infectivity, our contagiousness. And so but the only way, this is the first humans in human history that have been able to fight back to against a pandemic, because in the 1918 influenza pandemic, people just died. The first flu virus that hit us in 1918 killed about 2 million people worldwide, and the mutation, when it mutated and formed a variant, is about 50 million people. But now we're able to sequence the virus, identify a part of that virus called the spike protein, inject that, cause the spike protein to come about. That creates immunity and it protects us. So this is the first time in human history we have the technology to actually fight the actual pandemic. So this is very important. It's actually going to save millions of lives across the world.
So let's talk a little bit more. That's you've opened up so many avenues for me to ask questions here. But let's talk a little bit more, a little deeper into the virus, especially as it relates to African Americans. We know that here in Detroit, it was some 3 times more deaths per capita than throughout the rest of other communities. I'm concerned because I really want the audience to know, why has it hit our people so hard? Why has it been almost 3 times as much of a jolt to our people here? And why are those disparities there? Are there co-determinants of those disparities? Are there other kinds of comorbidities, other kinds of chronic health conditions that exacerbate that kind of a reality?
It's an extraordinarily important question. The disparity in COVID-19 infections and death rates among African Americans specifically, and other and Latinos, is not because this population, that is Black and brown people, are inherently more susceptible to getting the virus. We are not. It is because of the significant and disparate poverty levels and its related higher burden of chronic disease. African Americans are more likely to have pre-existing illnesses, like health illnesses like diabetes or asthma or hypertension or cancer or obesity, that make the coronavirus or COVID-19 particularly deadly. Higher poverty rates and higher burdens of disease are the results of 402 years of negative US social, economic, political, and health policies resulting from our enslavement, Jim Crow, lynching, segregation, inequitable justice system, all of this destroying the Black family, redlining, unfair housing policies, unfair employment practices, job discrimination, discrimination in educational policies, economic policies. All of these things have placed people of color, specifically African Americans, in marginalized positions. And all COVID-19 has done is simply expose how a long history of racial discrimination and institutional race-based policies have uniquely tied African Americans to the bottom of the US economic hierarchy. And so this has tremendously affected our community. Racial and ethnic groups are disproportionately represented, for example, among essential workers unable to work from home, resulting in higher risk from exposure of COVID-19 with potential secondary transmission among household members, including infants, children, adolescents, and young adults. The disparities in social determinants of health, such as crowded living conditions. So you have people who are the essential workers. They have to go into work, food service, et cetera. They're going into work, forced into work, can't work from home. They also, because of economic marginalization, live in more crowded living conditions, food and housing insecurity, wealth and educational gaps, racial discrimination. These contribute to the racial and ethnic disparities in COVID-19.
I see. So let's talk just a little bit more, and we're going to get into the vaccine, but
Okay.
just a little bit more about some of the historical things that have happened. Now, we know that the number one operative word in all of this is the word trust. It is a word, of course, that a number of our people are having very serious issues with, from the standpoint of government, from the standpoint of as the judicial system. I think we are all rejoicing tonight in the justice verdicts that have come down in the George Floyd case against the officer, and how the officer was found guilty of all charges there. A great step in the right direction, and yet there are so many other people who have been victimized by the same sort of a system, who did not receive the same hand of justice. And we understand that that's a co-determinant as well in terms of how people live. But trust is the big word.
Yes.
Trust is the big word. There's mistrust in government. There's mistrust in the medical system, historically. And this is why I look up to great men like yourselves and great women like your colleagues in the medical field, who are people who lead the way in terms of our medical information and medical practice in this day and time. How have those things played in to the trust issue and the trust factor that so many people have?
So another very important question, and what you're getting at is vaccine hesitancy. And that is, there is current mistrust in the Black community, largely fueled by both current situations and our past experiences of medical experimentation and abuses of African Americans in the United States. And, the infamous Tuskegee study that was conducted by the US government from 1932 to 72, which involved Black men who thought they were receiving free healthcare, but instead they were involved in a study without their knowledge, without their consent, of the effects of untreated syphilis. These were men who were known by the government to have syphilis. They were not treated. And that impacted their families because they passed it on to their wives, they passed it on to other people within their family structure. Things like Henrietta Lacks, a Black woman treated unsuccessfully for cervical cancer in 51, and they kept her cells and have used her cells for medical research for the last 50 years. Or J. Marion Sims, who was known by the larger majority community as this sort of revolutionary gynecologic father of gynecology for the United States, but who did multiple experimentations on enslaved Black women and basically did gynecologic procedures without anesthesia. And many of these women were permanently harmed or died. And so these kinds of things clearly impact our family. But I say, while perceptions of the past abuses are important, the most significant contributor to distrust in what Black and brown people see and experience every day in their lives, like Michael Brown, Tamir Rice, Walter Scott, Breonna Taylor, and now George Floyd. They see these things happening. And we just had in 2020, the allegations of women held by US Immigration and Customs Enforcement at that detention center in Georgia that were forced to undergo unwanted hysterectomies and other unnecessary gynecologic procedures. That was 2020. So these are things that they're seeing in real life. You're seeing on national TV that a police officer in front of the whole world kills a man with his knee and chokes him. And what is happening then is, that same system, now community members are skeptical. That same system is asking people to come in and take a vaccine. And so, what I've told Pfizer, what I've told Moderna, what I've told these companies when we meet with them, and their leadership is to say, you're rolling out a vaccine without rolling out the education and the messages and with the appropriate messengers so people are comfortable with what is going on. Most people, once they understand this vaccine, will take it. When we received it in our practice, 100% of the physicians took it and 100% of our MAs did not. And that shocked me because these are medical people, et cetera. I sat down with them for an hour and a half, all the staff, there were 30 staff. And after an hour and a half of answering all their questions, which there were lots of myths, after answering all their questions, 28 of the 30 took it. About a month later, the 29th person took it. So when people are intelligent, once you sit down and take the time to address their concerns, people are more comfortable in taking the vaccine because, I took it, the first vaccine that was given was December 14th. I took mine December 18th. My wife took hers, who's a pediatrician, took hers December 20th. And, I don't have any horns or a tail, nothing has happened to me. I took it because I really reviewed all the data and I understood that it was safe and it was effective. And I try to tell other people that it's safe and effective. And once you answer their questions and you address their concerns, people actually become more comfortable taking this vaccine.
So quickly, tell us, just answer that question. Is it safe, and why?
So yes, it is safe. People there are a lot of concerns, especially the mRNA vaccine technology, the Pfizer and the Moderna, and that, it was developed too quick and they cut corners and all of this. But the scientists have been working on mRNA technology for 30 years. The technology is not new. It's a myth that people are saying it is not. Its application in a vaccine is what's new. And that application was thought of and put together by an African-American PhD, an African-American woman, Dr. Corbett, out of the Vaccine Research Center in the NIH. She thought of taking this 30-year technology and combining it with a vaccine. And that's why we've been able to ramp up so quickly in applying the mRNA technology to a vaccine, because of 30 years of science and research. The vaccine does not play around with your chromosomes. It does not affect your genes. It does not affect your DNA, or does it go into the nucleus of the cell. The human cell is made up of a nucleus and then cytoplasm. The vaccine is an already produced piece of mRNA, a messenger that simply goes into the cytoplasm of the cell, not the nucleus where your chromosomes, genes, and DNA are, doesn't even go there. And it tells your cell to produce harmless pieces of those little spiked proteins on the virus. Those spike proteins evoke an immune antibody response and kills the virus. So it produces those spikes. The antibodies form to attack the spikes. And every time your body sees spikes, so if you're infected with a virus, every time your body now sees spikes, those antibodies attack it and kill it. Each one of the vaccines, the Johnson & Johnson, the Moderna, the Pfizer, and also the AstraZeneca, were each in clinical trials. They each had about 44,000 people in them. About 13% or so were African Americans in these studies. About 16 to 17% were Hispanics. They had a lot of Black and brown people in the studies. They were shown to be, the Moderna and the Pfizer was shown to be 95% effective. That means if you take the vaccine, you have 95% chance of being protected from the virus. You still have a 5% chance of getting the virus, even despite vaccination. However, you don't get severe disease. You don't end up being hospitalized and you don't die. No one who has been fully vaccinated in the world with these vaccines have died from COVID. So the key is getting vaccinated. The J&J has about a 70% effective rate, very safe. And it has a less effective rate because it was tested during the time when there were more variants within the United States. So the Pfizer and Moderna were tested more when we predominantly had the original virus. The J&J was tested with not only the original virus, but we also had variants in the country. So there's a slight decrease in the effectiveness rate, but it doesn't matter. Doesn't matter which vaccine you take. They all protect you from severe illness, hospitalization, and death.
Well, that's great. That's great. We're talking with Dr. Herbert Smitherman, who is Vice President, of course, of the School of Medicine at Wayne State University, Professor, of course, of Medicine as well, and the CEO of the Detroit Health Centers throughout Metro Detroit. And this is a tremendous conversation that you ought to be not only watching for yourself, taking good notes, going back to the YouTube page and subscribing there and getting an opportunity to see this again. But you might want to text somebody right now and let them know that I'm on with the VannTage Point with Dr. Herbert Smitherman. And we are going to press forward and give you even more information about the COVID-19 vaccine, because we know that we are literally in a race right now against the mutations and the variants that are out there. Here's what we don't want to happen. I want Dr. Smitherman to talk about it. We don't want to lag behind in vaccines to such an extent that another variant gets an opportunity to proliferate in our community. We don't want that to happen. We're seeing what's happening with this particular surge that we're having. Now, Dr. Smitherman, a couple of things there. You mentioned young adults. I did a whole entire VannTage Point with young adult leaders talking about the vaccine. And there's not just hesitancy among young adults. For a lot of them, it is just merely, I am not going to take it. They're adamant about not taking it for a lot of different reasons that we've already talked about. Some of the myths that you have already exploded tonight so that they are no longer excuses for us, but also in terms of just having an anti-vaccine mentality, in terms of knowing that all of the information about this particular virus is not yet available. The Johnson & Johnson hiccup that happened on last week, I suppose, and other kinds of things that cause people to not just have hesitancy. They were already hesitant, but many of them, because of whatever conspiracy theories, things they're seeing on social media, reports of other people still getting the vaccine after they've been, the virus after they've been vaccinated, etc. Only buttressing some of their very strongly held opinions about it in the first place. What would you say to young adults? And I know that the messaging for them probably has to be different, and the messengers. You know, I acknowledge my age, and I know that maybe I'm too old to talk to them or to message to them in a way that would be palatable. What would you say, though, as a medical professional to young adults in the demographic that you talked about, up to 39, people in their early 40s, et cetera, who are adamantly against taking this vaccine?
Mm-hmm. Yeah, it's a good point. I always say formulating the right message and the right messengers, and also eliminating the functional barriers for both testing and vaccination are critical. So if for, I'm with you as far as age. So I don't know if I'm the right person for the messenger and perhaps the messenger, but we need to get young people together to figure out what their concerns are and have them help us develop what that message is and who the right messengers are for that community, that age group. I mean, we might not be the people to actually convince them, but they are. They know what their concerns are. They know why they're not doing it. It is, I just say in my experience with my patients, it's been relatively rare. I mean, I say maybe if people come in and you have a group of people, there are three groups of people: those who instantly say, no, I'm not taking it; those who say, yes, I am; and those who are kind of saying, I'm going to wait and see, if my next door neighbor who took it grows horns. So
Right.
you're going to have to, I'm going to see, this to show me. So, when we sit down and I talk with them about what their questions are, what their issues are, and we go through it, I'd say about 80 to 90% of people convert to taking it because they have, there are all kinds of myths, out there. The sort of the common ones, when I talk to people, the COVID vaccine is not safe because it was rapidly developed and tested. We talk about that. And I talk about, there's a Black woman who developed it. Okay, this was an African-American woman, an immunologist who developed this vaccine. And of course, she's not going to develop something that's going to hurt people. And I already, I've already had COVID, I've recovered, so I don't need to get the COVID vaccine. No, there's not enough information currently available about, whether someone, first of all, how long after infection someone is protected. And we don't know how long the natural immunity lasts. We are recommending strongly that they get vaccinated. People say to me, people will die as a result of the negative side effects of COVID vaccine than would actually die from the virus. Absolutely false. The side effects are very minimal. They usually last from 1 to 3 days, if any. I didn't have any. My wife had some on the second shot. People talk about the biggest one, and people are, it affects my DNA. No, it doesn't. I've already talked about that. There's this whole issue and this myth about that they're going to put sort of these nano transducers in our brain, and that they're going to have microchips or tracking, with getting vaccinated. And this myth started after comments made by Bill Gates and the Gates Foundation about a digital certificate of vaccine records. That was a vaccine passport, and people misinterpreted that as some vaccine microchip. There is no such thing. I have a lot of women say that the vaccine it will cause infertility or miscarriage. First of all, no vaccine on the market does that, and the COVID vaccine, COVID-19 vaccine, has never been linked to infertility or miscarriage. We've not seen that at all, even in the clinical trials. It was developed using fetal tissue. That is not true. I mean, there's just a whole lot of these things. And when you sit down with people and you walk through whatever their concerns are, they go, okay, I got it. But the message has to be there, and the messenger has to be there. And I think if you want to message young people, you have to have young people developing that message and also are the messengers for it.
So what about the J&J, the Johnson & Johnson vaccine, and the threat of blood clots that took place in a few rare cases there? And we're still waiting word, possibly on Friday, we've been told, about whether or not or how that would continue, or whether or not it needs to be studied even more. Is there something different about Pfizer and Moderna as opposed to Johnson & Johnson, it being a one dose? There were a lot of people who wanted to say, well, okay, if I'm going to take it, I'll take one dose. That's it. Because I heard people get sick on the second dose. I never got sick. I've got, some chronic conditions and other things going on, but I didn't get sick on either one. But I know that there are a number of people who are concerned about what they heard about Johnson & Johnson. What's your take on that?
Okay, first of all, the Johnson & Johnson, the issue was there were 6 women in the United States who developed some unusual clotting. And this is after 7 million vaccines were given. So you're talking about essentially, less than 1 in 1 million. So for every one person that was vaccinated, 1 out of the 1 million people developed this clotting. And if you look at something like birth control pills, for example, and the very common medication provided in the United States, 1 out of every 3,000 women will develop a blood clot. 1 out of 1,000, not 1 out of 1,000,000. And what we don't know is, we don't know what the rate is in the general population. What the pause is doing is that the researchers are coming together to give us information about what is happening with respect to these blood clots in the general population. If those in the general population are actually higher than in the vaccine, then we know that it's not the vaccine. The second meeting is on April 23rd, I believe. And so they've already had one meeting. They'll have another meeting. This should be weeks, somewhere within the next week or so, we'll have some information. But even if it is a clot, it is 1 in 1,000,000. One person develops it in a million vaccinations. And so this is, and I believe you're probably going to see, this is my granddaughter coming to me. Hold on, sweetie. Poppy's on the phone. So it's 1 in 1,000,000. And so I'm saying, even if it is positive, even if that is case, it's still a very rare occurrence. But I believe what's going to happen is that we're going to find that it's actually a much higher rate in the general population, and the pause will be lifted, just like the pause was lifted in the AstraZeneca, and it will continue. Europe has already lifted the pause. So it was paused in both Europe and it was paused in the United States. Europe has done their evaluation and they have lifted the pause, and they are now continuing Johnson & Johnson in Europe. We have not done that. We still think there needs to be some more evaluation, but it should be coming soon. And I believe we will lift the pause also.
Great. I want to talk about another demographic in our community, because there is a demographic in our community that is always pretty hesitant about medical care, and that's Black men. I know that Black men struggle because I've had my struggles before. I sat in your office several times and discussed some of those struggles. And I've been very grateful for you and others like you who have helped to really give Black men a sense of strength and a sense of understanding about the propriety of our own healthcare. Black men often are those who typically don't want to go to the doctor, don't want medical treatment, many times forego routine things that ought to be done. And as it relates to this virus, I can only imagine, I haven't seen stats yet, but I can only imagine that men who are reticent about their own health care on a normal basis would be reticent about this vaccine as well. What would you say to Black men in this hour about the COVID vaccine?
So Black men and most men in their 20s and 30s, they think they're invincible, so they don't visit doctors. Like, women start engaging with the medical community because of pregnancy. They engage early and they're used to going to the doctor, and they become comfortable with the doctor. Men, especially Black men, don't, and especially the history of abuse, et cetera, they are concerned because there are only 3% Black physicians in the country, and we're 13% of the population. So and then when men get into their sort of 40s, 30s, and 40s and 50s, they get very busy. And then they start getting into their 50s, 60s, and they get scared. And so they're frightened because they think somebody's going to find something. What mostly happens, and what happens in my practice and many practices, especially with Black men, it's the Black women in their families who get them to come to the doctor. Oftentimes on the first couple of visits, they're dragged in by them. Either their wife is complaining that they need to go, or the wife actually brings them to the visit and is holding them by their ears while I'm talking to them. And once they get comfortable, they understand there is no boogeyman here. We're not doing anything to you. And they become comfortable, and then they start going on their own. It's actually that first visit or two and getting them there is the key. And most of the time, it's the women in our community that actually make sure that happens. And so I will tell, African-American women have to shoulder so much in our community. This is just one more thing. You got to get your men in and get vaccinated. Drag them in, whatever, put them in the car, put them in the trunk, whatever you got to do, and get them to our practices, and we'll vaccinate them. So, that's really what happens in my experience.
Well, I want to hit another one of the very delicate areas, and that is often people of faith have issues with medicine. Some do, some don't. There's sort of this faith versus science, science versus faith, and I have to believe, even as a person of faith, that God created science because he created us, he created the universe, if that is our basis of belief. Certainly, the Bible says that there was not anything made that was made that he didn't make in the book of John. And so we know that faith is an integral part of this, and yet faith has sometimes been set up over and against science. And there are people who are struggling, faith people who are struggling in their faith to say, well, whatever I get, I think God can heal me. And I certainly believe in divine healing. But they are also saying to themselves, maybe I don't need to go get that vaccine. I'll just pray and ask God to cover me. I don't need to do this. I don't need to do that. And I know that there's a lot of irony and hypocrisy in that. A person has high blood pressure, they go get high blood pressure pills. If they, they go get fertility pills if they're going to get. So we utilize medicine in certain areas where there is fear and not courage. We sometimes want to mask it with faith. And I just wanted you to address sort of the faith versus science idea as well, because there are those who are out there who are saying, wait a minute, I'm a person of faith. I shouldn't have to depend on a vaccine. I shouldn't have to do this. I shouldn't have to do that. When we know that good health is just as biblical and just as spiritual as anything else. So I'd like for you to just touch on that if you would.
Yeah, so, I understand this topic is very sensitive, and it also is important within communities of faith. I am a person of faith, and I believe that we are made in his image, which includes a brain. And that brain allows us to develop entities that help the protection and safety and well-being of humans and the planet. So I will tell people that, I use my brain, I think about things to help others. It is my service, and it is the way I practice my ministry. My ministry is through medicine. And my ministry is to help people stay healthy, to live productive lives. And I will do everything in my power to do that. Now, there are lots of other issues of faith within the vaccines, like, people are concerned about, do the COVID-19 vaccines contain aborted fetal cells? They do not. Do they, some are talking about the gelatin that's used to oftentimes stabilize the vaccine and the drug's ingredients. Do the gelatins contain pork or cow products? They do not. And many people of faith are not interested in having pork or cow, et cetera. So if you talk about just some of the basics issues around faith, aborted fetal cells, pork, cow products, et cetera, none of that are a part of the vaccines. And the other part I've talked about, and that is, I believe that as a person of faith, that, what I do in my ministry as a person of faith, because people of faith are to help their fellow man and fellow woman, that what I do and what I practice is my help. And what I can do is help you be the best person, the healthiest person, improve your well-being, and do that with the brain that God gave me.
That's great. That's great. There are those that, again, conspiracy theories will lead people to believe you're being injected with the sign of the beast. You are, computer chips are being put inside. That's how they're going to get computer chips in everybody. They're going to follow you. They will know all of your data, and et cetera, et cetera, et cetera, et cetera. There is a lot of, again, mistrust, especially where technology is concerned, because it has become so pervasive in our lives. And of course, the plans for the future is that technology would be even more pervasive. And so people need to know that they're not being injected with a microchip. They're not being injected with, some other kind of remote technology that's going to, clone DNA and lead to designer babies and a bunch of other things that are being discussed in the scientific community. I know that you have a philosophy toward urban health, and that philosophy towards urban health has to be a practical one. Tell us a little bit more about what you feel philosophically. As you say, your ministry is medicine. So how do you feel personally really about making sure that people are healed and whole?
And another important question. I feel the first step in that, if you're going to have appropriate messages and messengers in communities of color, is you have to have practitioners as a part of the medical workforce. So one of my ministries is to make sure I help in develop pipeline programs in K through 12 in college to help get more physicians that are Black and brown in medical school, because it's important, if our community is going to negotiate these issues of science, that they have people that look like you and me from communities that where you and I come from, that are at the table understanding the data and can translate that data as a trusted messenger to our community. It's hard for communities to have that kind of trust if we're not at the table. So the first step is, from my standpoint, is we've got to have more Black and brown physicians, nurses, people in healthcare. And that's been a big part of my mission as I get more young people into Black and brown young people into medical school, get them trained well, get them into excellent residencies so they can be practitioners within our community. And also try to select people who are interested in practicing in urban communities. It's also trying to look at what impacts a person's health. About 70% of it are social determinants of health. That is, food insecurity, housing, transportation, education, jobs, employment status, policies in the country. What I do as a medical doctor impacts your health about 25%. Mostly what impacts your health is, do you have food? Do you have housing? Do you have a job? And it's also looking at health in a more broader way. That is, we are not only looking at this person as a person who has hypertension and giving them drugs, we're looking at this person to make sure, do you have appropriate housing? Do you have appropriate job? Do you have an appropriate access to education? Do you have food security? These housing security. So in our practice, we look at the human as a very broad entity, that we're also addressing the social issues that impact their health and not only the medical issues.
So there's mind, there's soul, there's spirit, there's body. Right. And the true definition of good health is for all of those things to be in balance. It's kind of like the scripture that says, I wish above all things that you'd prosper, be in good health, even as your soul prospereth. And so it is all of those things coming together to form a synergy within us that really God intended in the first place. And so to address people of faith, it's good for them to understand that, we're not healthy with some of the, funeral repasts that we have, some of the picnics that we do, some of the family reunions are not healthy. And a lot of the things that we are doing are not healthy, and we need to get it together. Dr. Smitherman, this has been such a tremendous opportunity to spend a little time with you one-on-one tonight, for you to share with us your expertise in such a plain way, in such a way that is easily understood by so many. We look up to you. We honor you, sir, because not only are you an expert in your field, but you have a passion for your work. This is not a job for you. This is, as you say, a ministry. This is, as you say, a mission. This is, as you say, you actualizing your purpose in the earth. And there are 2 days that are significant in our lives: the day you were born, and of course the day you find out why. And you found out why, and you are certainly the epitomization of that in our community. I don't know, it looks like you got 5 or 6 jobs. You're trying to keep up with me. But we want to thank you really, really for this opportunity that you've given to this community, to hear the facts, to listen not to myths and not to excuses, but to realities for us as it relates to COVID-19, the virus, and COVID-19, the vaccine. And it's kind of, you've given to us and made the case, it's vaccine or virus. We've got to be very, very clear as a people about that. And we're looking to Black medical experts like yourself to continue to lead us in this path as God has given you all of this knowledge and wisdom. Your last thoughts for us as we get ready to close.
So first of all, thank you for those kind comments. I would say my last message to my community is that Black and brown people are dying at 3 to 4 times higher death rates than non-people of color, and that it is critical that you get vaccinated. No one in the world has died from COVID-19 after being fully vaccinated. It doesn't mean you can't contract COVID, but the percentage is very low. And if you get it, you won't get severely ill, hospitalized, and you won't die. And I think, as your wife said it best, which I think I'm gonna use it now. She said, vaccine, vacation, or virus ventilation. That sums it up for me.
She said that. She told your wife that.
She told my wife that. I thought that was great.
That's great. That's great. We thank you so very much. Dr. Herbert Smitherman, renowned medical expert and professional in our community, a man who has the community at heart, the people of this community at heart, their health, their well-being, their balance in life. We've been privileged and pleasured to have him as our special guest here on the VannTage Point tonight. There are opportunities all over the city of Detroit and throughout the Metro Detroit area for you to get the vaccine. If you're watching us tonight from another area throughout the country, you check with your medical community there or your city, wherever you may live. I'm sure that there are opportunities there. There's almost vaccines on every corner in Detroit now. We've been very fortunate at the church where I serve. This is our 11th, 12th week of doing vaccines. Thousands have been vaccinated during that time. And I'm very, very proud of that. Make your decision and make it quickly before other variants and mutations come out, and before we can not get to a place of what I call community immunity. And we want to make sure we get there and get there soon. I think that everybody, warm weather's coming. I know it's a little cold tonight, but warm weather is coming and we really, really want to enjoy our summers and our various activities. It's not possible now until we make a decision. So decide to decide. That's your opportunity tonight. Decide to decide, because indecision is still a decision. God bless you tonight. I thank God for you, our guest, Dr. Herbert Smitherman, and on behalf of myself and the VannTage Point, have a great evening.
Thank you.